the study of audiological assessment in pediatric HIV patients. It was conducted in the year 2022. Coming on to the basic introduction of what HIV/AIDS is. As we all know, it's a chronic life-threatening condition caused by HIV, a retrovirus of the lentivirus genus. HIV weakens the immune system by drastically reducing the CD4 counts, making the body prone to opportunistic infections. And this virus carries diploid single-stranded DNA, which is converted to double-stranded DNA by reverse transcriptase. This viral DNA integrates into the host cells, leading to its proliferation, as we all discussed a moment ago. Now, coming on to the statistics. According to the GAP report in 2017, around 35 million people were living with AIDS, out of which 2 million children were affected. In India, India is basically having the third largest number of people living with HIV/AIDS. And in the world, it's around 2.1 million, which accounts for about 4 out of 40 people who are living with AIDS in India. The adult HIV prevalence has seen a steady decline over the years, from 0.38% to 0.26%, and there is improved antiretroviral agents to the patients now. So basically, around 20 to 40% of children and adults have access to ARVP in India. In children and adolescents, the disease might have been contracted from birth or via unprotected sexual intercourse, the use of contaminated blood products, and the practice of sharing sharp objects. Currently, in a developing country like India, improved access to ARV therapy not only promoted a longer life, but also led to an increase in diseases that had previously been underreported, hence emphasizing the role of recognition of the disease and early treatment. Among the many alterations or complications that HIV can cause, directly or indirectly, alterations in the auditory system stand out. Hearing loss of several types, like conductive, neurosensory, and mixed in individuals affected by this virus, can be associated with opportunistic infections, ototoxic drugs, and the direct action of the virus upon the auditory system. There is a growing concern about the deleterious effects of HIV on the ear. The frequency of these conditions is approximately 2 times higher in HIV positive population compared to the HIV negative population. Again, around 40 to 90% of the HIV positive patients will experience ENT diseases, and out of which, like 20 to 50% of HIV positive patients have reported hearing loss. It has been seen how the HIV virus affects the hearing is via direct viral impact on the CNS, via opportunistic infections, via immune reconstitution, and ototoxicity due to antiretroviral therapy. The immunocompromised state caused by HIV weakens host defenses, making patients prone to middle ear infections, which may lead to conductive hearing loss. Persistent lymphadenopathy can block the eustachian tube, causing serous otitis media. The SNHL component can be linked to direct neurotropic effects of HIV, affecting the cochlear vestibular system and CNS, as well as ototoxic drug side effects by the ARV therapy. Histopathological studies have shown changes in the vestibular hair cells, epithelial lining, and supportive cells of the cochlea, including the viral-like particles and structural abnormalities. These findings support the role of HIV in damaging the auditory structures. Again, all of this combined in an image, all this alterations in auditory system can lead to abnormal tympanogram, elevated auditory thresholds, and altered ABRs. Now, hearing loss in HIV-positive pediatric patients can be due to a number of reasons, like upper airway infection or sinusitis, which can lead to eustachian tube blockage, leading to otitis media, and hearing loss. It can lead to otitis externa also. Why? Because of the infections leading to the infection of the tympanic membrane and conductive hearing loss. Otitis media, as we just now said, which can lead to conductive hearing loss due to erosion of its ossicles, tympanic membrane perforation, and SNHL due to bacterial toxins damaging the outer hair cells on a nerve. Cochlear pathology can also be there or inner ear impairments due to direct action of the virus, as we just discussed. Antiretroviral therapy, which may or may not have ototoxic effects. Now, hearing loss makes oral communication difficult or impossible, directly impacting social and familial interactions. It creates stigma and affects self image, thus prompting a perception of incapacity and dependence, potentially resulting in an individual's marginalization. In children, it can interfere with education with obvious socioeconomic consequences. Therefore, early identification of pediatric hearing loss is essential for optimal language, social, and educational outcomes. We conducted this study because the information on such a topic is sparse. The literature is sparse. That's why we conducted this study. And it was important in this population so as to find out the incidence of hearing loss. Therefore, in light of what has been unveiled, the purpose of the present study is to see for audiological manifestations in 50 HIV positive patients. We use a sample size 50 according to the formula. We'll be using the investigations such as pure tone audiometry, impedance audiometry, and distortion product autoacoustic emissions for our study. And we'll also be taking into account the CD4 counts of the patient for its correlation with the hearing loss. Now, what were the aims and objectives of my study? To assess the otological manifestations in pediatric HIV positive patients, to assess hearing loss in pediatric HIV positive patients by audiological assessment, as we just discussed, and to correlate the degree of hearing loss with the CD4 plus counts. A cross-sectional study was carried out in 50 HIV positive pediatric patients. Age group was around 5 to 17 years, to observe the otological manifestations and assess hearing loss with audiological assessment, attending the ART clinic in Rajendra Hospital, Patiala, and to correlate the degree of hearing loss with CD4 plus counts of the patient. The protocol of the study was approved by the Institutional Review Board for the ethical clearance, and all procedures were performed in accordance with the Code of Ethics of the World Medical Association, according to the Declaration of Helsinki of 1975, as revised in 2000. The sample size was calculated using this formula, as we all know in the community medicine that we studied. With this, confidence level was set as 95%, margin of error at 5%. Population proportion, according to NACO website, how the HIV is affected is 3.4%. So according to this formula, when you fit all these values here, the sample size comes out to be as 50. This means that 50 or more sample sizes needed to have a confidence level of 95%, that the real value is within plus minus 5% of the measured value. Now, for our study, we have taken inclusion criteria as age group between 5 years to 17 years, confirmed cases of HIV/AIDS, and consent for participation from the parent or the guardian. Since the patients that we in our study we're using are minors. Next, exclusion criteria that we took, it's a long list. Basically, we're excluding patients who are having history of previous hearing loss, let's say congenital, a hearing loss due to other systemic causes such as syphilis, diabetes, neonatal hyperbilirubinemia, patients with pulmonary or extrapulmonary TB, family history of hearing impairment, history of ruling out genetic component, history of accidental exposure to loud sound, descent of the participation of the parent or guardian, and non-cooperative children. This is just an overview of what we went through in our study. For our impedance audiometry, we used a commercially available tympanometer, Interacoustics 8235. A 226 Hertz probe probe tone was used for tympanometry, with pressure varying from negative 200 to positive 200 Dalton Pascal. Autoacoustic emissions was carried out using systems developed by Myco Diagnostics Euroscan. DPO is performed for each patient. Hearing results were analyzed statistically using IBM SPSS version 22. Descriptive statistics was done for all data and were reported in terms of mean, standard deviation, and percentages. Appropriate statistical tests of comparison were applied, just these tests, chi-square test, Mann-Whitney U test, and Pearson's coefficient for correlation. Statistical significance was taken as p less than 0.05. Now coming on to our observation and results. For our observation and results, as we discussed, our sample size was around 50 and uh, 50 patients. So dividing them into the classification of years. So if we take 50 patients, we have 100 years. So that's how we did our study for our calculation and for the calculation and all. Location was an ART center in Rajendra Hospital, GMC Patiala, Government Medical College Patiala. And the age range was around 5 to 17 years, mean being 9.34 plus minus 3.19 years. We use this age group because this age group belongs to the school-going population, and any hearing loss at this age can affect the academic performance and lead to poor social skills. And and for our study, the gender distribution was around 54% of males and 46% of females, with male preponderance. And for socioeconomic status, for the patients that were predominantly lower middle class, like around 68%. And this classification, the classification that we used for this study was modified Kupuswamy scale. Now, as for before coming on to this hearing loss, the majority of the patients were undergoing antiretroviral therapy. Most of them were going through antiretroviral therapy, and they were going on different regimens basically. So for the regimens, around four uh, uh, around 4% were on abacavir, and 8% were on ALD, which is abacavir, lamivudine, and dolutegravir. 18% were on abacavir, lamivudine, and efavirenz. 56% were on tenofovir, lamivudine, and dolutegravir regimen. 2% were on tenofovir, lamivudine, efavirenz, and 6% were on zidovudine, lamivudine, and efavirenz, and were on zidovudine, lamivudine, and nevirapine. So out of this, majority were on the TLD regimen, tenofovir, lamivudine, and dolutegravir regimen. Lamivudine was given to almost all of our patients in our study. So except for the regimen that the patients were taking of abacavir. So lamivudine being the common denominator for all. Now coming on to the hearing loss, the otological complaints first of all. The otological complaints, hearing loss. Okay, so 2% of them complain about left ear tinnitus. 6% complained for bilateral ear tinnitus, 4% left ear hearing loss, 6% right ear hearing loss, and 12% bilateral hearing loss. 2% complained of right ear discharge, and 4% complained for bilateral ear discharge, and 2% complained for about ear itching. Simple complaint of ear itching. Now coming on to the hearing loss prevalence. Around 21% of patients had hearing loss on pure tone audiometry, out of which 16 had sensory neural component, 3 had conductive hearing loss component, and 2 had mixed hearing loss, both conductive and sensory neural component. Out of these 21 years, depending on severity, 17 had mild hearing loss and 4 had moderate hearing loss. Out of 17 mild hearing loss were a sensory neural component and 3 were conductive hearing component. And 4 out of 4 moderate hearing loss, 2 were sensory neural and 2 were mixed type of hearing loss. And in impedance, total 5 years were found to be abnormal, and the rest were normal, for which out of 50 right ears, 2 were abnormal, and out of 50 left ears, 3 were abnormal. And in the distortion product autoacoustic emissions, 53% of them showed abnormal emissions. So it was shown at 5.18 or plus minus 0.62 decibels, and the normal frequency was at 11.48 plus minus 5.58, 5.54 decibels. So we'll discuss the significance in a moment. Basically, what is happening here is that for Puritan audiometry that we discussed, although the conductive hearing loss component is the principal type of hearing loss in HIV positive patients, there was a preponderance of the sensorineural hearing loss in our present study. This can possibly be because we have excluded the patients with opportunistic infectious chest tuberculosis and systemic illnesses. The direct effect of HIV might have played a role in this discovery. Overall, the prevalence of hearing loss in any ear among children with HIV infection in the study was 21%, which was similar to the RAPCAC study et al., which was conducted at 2016. And that study had 24% prevalence of hearing loss, and most of the previous studies. It was similar. One of the possible explanations for this prevalence being 21% could be that of the definition of the hearing loss used in the study was according to the WHO classification, which is the threshold is more than 20, where the hearing loss uh, is uh, is said when the hearing threshold is more than 25 decibels. Due to this, like many studies might have taken the hearing threshold as 20 decibels or not in accordance with the WHO classification. So, because of this inconsistent definition of hearing loss in their studies and some of the previous studies, even though WHO has classified it as 25 decibels, comparison of prevalence among studies can be difficult when different cutoffs are used. So, another one that West Houston et al. In 2013, their study had 14% of hearing thresholds beyond 25 decibels, which was lower than our study findings. Like they had 14%, we had 21% of patients coming up with hearing loss. As for impedance, we had discussed 5 years in total were found to be abnormal. And in DPOE, we had 53% of years which had abnormal OA. Now, these abnormal OA results suggest abnormal outer hair cell function in these years. A clear indication of cochlear involvement was observed in 53% of the patients included in the study. As the hearing thresholds increase, the possibility of the recording normal OAs gets significantly reduced. The fact that patients who had a normal hearing with abnormal OA could be attributed to cochlear pathology, either due to ototoxicity or HIV infection itself. The consequence of HIV infection on the auditory system is central auditory nervous system abnormalities, some of which can be measured with auditory evoked potential, which includes mainly ascending pathways, that is efferent pathways. As 95% of the ascending nerve fibers supply to the IHCs, inner hair cells, and 5% to OHCs, outer hair cells, and in the efferent fibers, 90% to OHCs and 5% to IHCs. There is a possibility that efferent pathway may also be affected, which may lead to impaired OHC function as it controls the as it controls directly. The same may be applicable to the present study too. Now, we compared this finding of OA with other studies, like in study conducted by Ranjan et al. In 2008, excluding all abnormal PT and impedance audiometry, total of 27% patients got 50% abnormal DPOA results, which is almost similar to our study. Rapsack et al. In 2016 had 79% of years referred and 21% of years as past results. Similar studies had certain findings in these studies. Now coming on to the CD4 counts. Now CD4 counts, as we all know, more than 500 is normal. 350 to 500 is mild, and 200 to 350 is around advanced, and less than 200 is severe. So, considering that classification of CD4 counts, low counts of CD4 counts have been reportedly associated with neuronal degeneration in HIV positive individuals. Uh, so coming and having this knowledge of CD4 counts, which also indicates neuronal degeneration, in our study, we had uh, 48% of patients who had normal CD4 counts, 38% had mild levels of CD4 counts, which is around 350 to 499, and 12% had advanced, and 2% had severe. So out of the 38% mild, nine uh, 9 years had hearing loss. 9% had hearing loss, and out of 12% of advanced, 9% had hearing loss, and out of 2% of severe, 2% had hearing loss. So all of this will make sense when we'll discuss the significance. Now, significance for gender, we had 54% of prevalence, male preponderance. So uh, here it is showing significant higher prevalence in females. Uh, but our study could be erroneous because it had a male preponderance. Age and socioeconomic status was not significant, not associated with the hearing loss. ART regimen that was followed, it was not showing any significance, any association with the hearing loss. For as for impedance in DPOE, there was strong association with the hearing loss, as we could see the p-value. CD4 count had strong inverse correlation with the hearing loss, as we saw here. Our R value was negative 0.42%, 424, and p-value was 0.001. Meaning lesser strong inverse correlation, meaning lesser the CD4 count, more the occurrence of hearing loss in the patient. Our study highlights a high prevalence of hearing loss among HIV-positive pediatric patients with abnormal findings on pure tone odometry, impedance odometry, and distortion product autoacoustic emissions. A significant correlation was observed between CD4 counts and the degree of hearing loss. Additionally, various audiological manifestations were documented. Notably, the study underscores the potential of DPOE as an early screening tool, even before the clinical symptoms emerge. This was a cross-sectional study without routine longitudinal audiological monitoring during ART, and it lacked an HIV negative control group. This was the limitation of our study. So, as for recommendations for a better study after this, could be a further research with a larger sample size and longitudinal design is needed to better understand middle and inner ear involvement in HIV positive children, and a longer duration of study as well. Early detection is crucial to prevent delays in speech development, academic performance, and social integration. In investigating additional contributing factors affecting hearing in HIV positive individuals is also warranted. This is just a table to compare of all the studies that we had just discussed earlier. Um, just uh, con- just uh, um, just comparing all the studies in one image. This is to summarize the whole study that we just discussed. Thank you.
That was an excellent presentation. Hope all the participants have learned and benefited from you sharing your views. If anyone has any queries and questions, you can raise your hand or type it in the chat box.
So with this study, basically we can conclude that for HIV positive individuals, we should have them follow up in ENT OPDs even if they don't have any complaints of hearing loss. So we can conduct these studies on them, such as the DPOE or impedance, so as to find out any component of hearing loss that is emerging in these patients, so that they can have a much fulfilled life and better academic performance. That was the ultimate goal in my study.
Everyone. The natural course of surgery is to invent or innovate techniques in the hope of making treatment modalities safer for patients. Oncologic surgeries had a long history of radical excision that proved to be morbid to patients. But today, I will introduce you to a relatively new surgical technique. I am Ariel Laudentia, third-year resident of ORL HNS, and this is a case series in the versatility of submental island flap in oral and oropharyngeal reconstruction. Oral cavity cancers rank 6th among all malignant cancers globally, with the tongue as the most frequently involved subsite. Among the types of cancers, squamous cell carcinoma constitutes about 90% of the cases. Patients who are diagnosed early are good surgical intervention candidates, and surgical reconstruction of oral cavity defects is mostly addressed using eggshell flap. In our experience, the pectoralis major myocutaneous flap, or PMMF, is mostly employed, mainly due to the late diagnosis, advanced nodal disease status, and large defects that need to be excised or reconstructed right after. This case series comprises of 5 patients, aged 24 to 75 years old, who had primary malignant tumors in the oral or oropharyngeal cavity. All 5 patients underwent surgical excision of mass with reconstruction of defect using submental island flap. We employed the flap on these patients regardless of their nodal disease status, while making sure that it did not compromise the flap design. Patients have been followed up by at least 1 month, and the following is a summary of the patient profiles. In each of the 5 cases, the time it took to reconstruct the defect using submental island flap was approximately 1 to 1.5 hours. The average length of hospital stay was 17 days. However, patient 4 was made to stay for 28 days to observe the healing of the dehiscence on her donor site. In all of the cases, the flap demonstrated versatility owing to the absence of any signs of circulatory compromise or necrosis. This is the operative photo of placing the flap into the recipient site. This is on the actual patient, patient number 1. The post-operative sites for all cases showed good healing and aesthetic outcome. This is for patient 1. Here is the surgical outcome of patient 2, patient 3, patient 4, and patient 5. All 3 male patients presented with hair growth on their cutaneous paddle. Patient 4 showed dehiscence on the donor site, which was managed with tertiary intention, and no further dehiscence was noted. 2 out of the 5 patients underwent post-operative chemotherapy, while 2 were subjected to radiotherapy. 1 patient is still awaiting subsequent radiotherapy. Of the male patients who experienced hair growth on the cutaneous paddle, patient 1 noted its disappearance after chemotherapy. 1 patient expired 10 months post-operatively while undergoing radiotherapy due to aspiration pneumonia. None of the patients presented with disease recurrence on the primary site. However, patient 1 developed regional metastasis on the contralateral level 2, 10 months post-surgery. The flap and the donor site were grossly unremarkable. In general, the decision to use a certain flap is guided by a construct known as the reconstructive ladder. It is a list of options for reconstruction, starting from the simplest to the most complex, or what would require finer skills. The submental island flap falls under the regional flap technique, along with flaps like pectoralis major myocutaneous flap and delta pectoral flap. In our experience, malignancies of the oral cavity present with affectation of more than one subsite at the time of initial consult. With this, our head and neck surgeons are obligated to use large flaps such as PMMF. There is, however, a shift in the use of submental island flap in our institution for the past year, owing to the following reasons. First, it is easy to harvest with operative times far shorter than what we would usually consume when harvesting distal pedicled flaps like PMMF. Typically, harvesting PMMF would take 2 to 3 hours, as compared to our institutional experience of 1 to 1.5 hours for submental island flap. The hospital stay was also shorter in 4 out of 5 cases when compared to patients who underwent reconstruction using PMMF. The average stay for PMMF patients was 32 days. Second, the donor site of the submental island flap offers good camouflage options, as evidenced by patient 1. Third, it proved to be a robustly vascularized flap based on the submental artery, showing consistent survivability in all 5 cases. Fourth, as it is a flap that is adjacent to the primary site, it eliminates the need for a second procedure involving flap amputation, which is needed when using other interpolated flaps like the deltopectoral flap. Although in literature, the recommendation is to use submental island flap in patients with node-negative necks, in this study, we have employed it in advanced cases. In our results, the submental island flap demonstrated its versatility. On follow-up, the concerning point was the hair growth on the cutaneous paddle, and the apparent compromise in oncologic safety as claimed by other studies was not observed in this case series. However, the authors intend to do long-term follow-up of these cases to monitor tumor recurrence. While there is a possibility of transferring occult disease to the recipient site, proper flap harvest can minimize this complication. Physical examination, preoperative imaging, and intraoperative evaluation of the levels 1A and 1B are superior measures to ensure oncologic safety. We have also adopted the practice of performing neck dissection prior to harvesting the flap, thus providing the option to abandon submental island flap and use a different reconstructive option if the surgeon sees fit. Perhaps the 2 more important criteria in the decision to use the flap were the distance of the defect from the donor site and the size of the defect that would still allow primary closure of the donor site. In this study, we are able to demonstrate its utility in advanced nodal disease status without compromising patient safety. And with proper patient selection, the submental island flap proves to be a reliable and less morbid option for reconstruction. Thank you. Here are my references. And I would like to acknowledge Dr. Emmanuel Samson, my consultant and co-author and the main surgeon of most of our cases, to Dr. Ramon Carmelo Alcira, my consultant and co-author as well, and to Dr. Joseph Amado Galvez, chairman of the Department of Otorhinolaryngology, Head and Neck Surgery at Hospital ng Maynila. That's all. Thank you so much.
That was a very insightful presentation. Thank you for sharing. Any questions? There is a question in the chat box.
The question is from Dr. Emmanuel Samson, will the presence of submental node metastasis not compromise the blood supply during harvesting of the flap? What we do here in our institution is we dissect through the submental area for cases or for presence of any submental node. But we are careful in dissecting in this area so as to not compromise the blood supply. There had been cases that had been operated on in our institution wherein there is already a presence of the submental node metastasis, but in our results so far, even the presence of submental node metastasis has not compromised the blood supply and thereby has not compromised the flap. It just makes the dissection a lot more challenging, so to say. Thank you so much, Dr. Samson. Is it better than nasolabial flap repair? In cases of oral and oropharyngeal cavity, thank you, Dr. Kakoli-Roy. In cases of oral and oropharyngeal flap, in oral and oropharyngeal cancers, we find that submental island flap is even more superior, if we may, than our workhorse flap, which is the PMMF. I have not seen any studies yet that compared it to other flaps such as the nasolabial flap when we are talking about reconstruction of the oral and oropharyngeal area.
In King George's Medical University, India. Today's my presentation is about a morphometric study of the mandibular foramen, lingula, and the incidence of accessory mandibular foramina in dry mandibles. In the introduction, here, as you all already know, that the foramen situated on the ramus of the mandible on its medial surface is termed as mandibular foramen, and this act as a conduit to the inferior alveolar nerve and vessels. To determine the location of mandibular foramen is very crucial to avoid the injury of inferior alveolar nerve during inferior alveolar nerve blockage or surgical intervention. Here, on the medial surface, there is a tongue-shaped projection, which is known as the lingula, and almost 10 to 15% of failure rates of conventional nerve blocks are attributed to the structural variation of the lingula. The accessory mandibular foramina are the foramens other than the mandibular foramen, mental foramen, and the lingual foramens. How far away the accessory mandibular foramen is from the mandibular foramen is very significant, as the effectiveness of the inferior alveolar nerve block is impacted by the diffusion of local anesthesia. So now the aim of the study, the present study is aimed to locate the mandibular foramen from different bony landmarks on the mandible, assess the shape of lingula, and calculate the incidence of accessory mandibular foramina in dry mandibles bilaterally. Here in the material methods, the present study from August 2023 to January 2024 was carried out on the mandibles, on the adult mandibles bilaterally of unknown sex in anatomy department, KGMU, Lucknow, India. Total 30 adult dry human mandibles were taken for the study. Here, I calculated the sample size by a formula, and it is and by the calculation, it was about 25. So I took 30 adult dry human mandibles for the study, and ethical approval was taken from ethical committee before conducting the research. For the participant selection, for inclusion criteria, dry mandibles having socket for third molar teeth were included because the presence of the socket for the third molar teeth is considered as adult mandible. And for the exclusion criteria, deformed and broken bones, any pathology of mandible affecting the morphology of mandibles, bones on which any surgical procedure performed, such as the partial mandibulectomy, mandibular reconstruction, after exclusion of all such type of the mandibles, the mandible, total 30 mandibles were included in the present study. Now coming to the intervention variable, here we took distances of mandibular foramen from various bony reference points of mandibles were taken by the vernier caliper on the both sides of mandible, and these parameters were taken in millimeters, and here 5 parameters were taken. Mandibular foramen to anterior border. Here in the first photograph, you can see here I took MF-AB, that is from middle point of mandibular, from middle point of the anterior border of the mandibular foramen to the closest point of the anterior border of the ramus. In B photograph, here I took MF-PV, that is the from middle point of posterior border of foramen to the closest point of the posterior border of the ramus. In C, from I took MF-AG, that is from mandibular foramen to the most distant point on the angle of mandible. In D, here MF-MN is taken, that is from the mandibular foramen to the lowermost point of the mandibular notch. In E, MF-CP is taken, that is from mandibular foramen to the highest point of the pronoid process. And the novelty of the study is that I took this MF-CP parameter in additionally in the North Indian population, that was not done in the North Indian population before. And for removing the intra-observer and inter-observer bias, each reading is taken 2 times by 3 different observers, then mean of these readings is taken for a single reading. And for removing instrumental bias, same instrument is used by all the 3 observers each time. The tests such as the technical error of the measurement, TEM, relative technical error of measurement, RTEM, were used for intra-observer reliability of the measurements. For assessing inter-observer reliability, overall mean difference was calculated as per all the parameters. And here, assessment of the shape of the lingula was done by the observation. The shape was classified into the triangular. Here, this is triangular lingula, and where wide base and pointed tip is present. And it is nodular lingula, where entire lingula is merging with ramus except tip. This is assimilated lingula, where entire lingula is completely fused with ramus. And this is truncated lingula, which is having quadrangular tip. And this is mixed lingula, which is having variable size and shape of the lingula more than one tip. The shape of the lingula was also validated by the 3 different observers. It was reported in the percentage. Accessory mandibular foramina other than mandibular, mental, and lingual foramens and socket of the teeth were counted and reported. Incidence of these phenomena were mentioned in the was mentioned in percentage. Whole data was collected and stored in Excel sheet and then statistically analyzed by SPSS software. Descriptive and bivariate statistical analysis were performed. For continuous variable, pair t-test was used to check the mean difference. P-value is less than 0.05 was considered significant. Now coming to the results. In table 1, here, absolute technical error of measurement and relative technical error of the measurement values of all the parameters were calculated for the intra-observer reliability. And here, this is the value according to the first observer. These are the values according to the observer 2, and these are the values according to the observer 3. Here we absolute technical error of measurement, variable average value, that is the VAV, and relative technical error of measurement in percentage according to all the observers for all the parameters bilaterally. And for calculation of the absolute TEM and relative TEM and average and variable average value, we calculated according to the Perini TA et al. And here RTEM value of all the parameters according to all observers are very low. So are very low. That is from 0.13 to 0.27, and so that intra-observer reliability of all the measurements was very high. All RTEM values were within acceptable limit, that is 10%. Here we found only this value ranging from the 0.13 to 0.27. So the intra-observer reliability was very, very high. For assessing inter-observer reliability, overall mean difference was calculated as per all the parameters. For right MF-AB and left MF-AB, overall mean difference was 0.02 mm and 0.02 mm respectively. For right MF-PB and left MF-PB, overall mean difference was 0.02 mm and 0.02 mm respectively. So here for all the parameters, as we calculated the mean overall mean difference, that was ranging from the 0 mm to the 0.03 mm only. So as the value of overall mean difference was very low in all the parameters, so here inter-observer reliability of all the measurements was very high also. Now in the table 2, here we took measurement of distance of the mandibular foramen from the various bony reference points of the mandible in mm, and here mean plus standard deviation was calculated, mean difference, percentage mean change, and p-value and t-value. These all are calculated. But in this table, as you can see that here the p-value is more than 0.05. So it signifies the null hypothesis, and that is there was no difference in location of mandibular foramen when we compare mandible bilaterally. Now coming to the table 3, here shape of the lingula is here shape of the lingula is classified in percentage bilaterally, and according to our study, most prevalent shape of the lingula in both sides of the mandible was truncated, and least prevalent shape of the lingula in right side was asymmetric, and in the left side it was triangular. Okay, but this is according to the North Indian population. We didn't find any mixed type of the lingula in the present study. Now, for the incidence of the SSC mandibular foramina, here I created this table, and here from this table, I can say that in present study, SSC mandibular foramina were present in 36.67% mandibles, mostly on the medial aspect of the mandibles. Unilaterally, its incidence was 13.33% in the right side and 6.67% in left side. Bilaterally, its incidence was 16.67%. Now coming to the discussion, for the location of mandibular foramen, the awareness of the location from different bony landmark of the mandible is very important, because it is impossible to palpate foramen from inside the oral cavity or from surface superficially. The advancement of the implant techniques has heightened the interest in the anatomy of the mandible, particularly in accurately locating the mandibular foramen. August et al. Here I created a table for the comparing the finding of my present study with the authors, with the other authors, and here August et al. Performed the study on the Turkey population, and concluded that the mandibular foramen was located posterior to the center of the ramus of the mandible on both sides. In the present study, we also found the same finding, which also coincides with the study done in the South and North Indian population mentioned in the table 5. And the following points can be suggested by the present study in North Indian population. First, for the successful inferior alveolar nerve blockage, local anesthesia should be injected posterior to the center of the ramus of the mandible. Second, if a fracture line is present posterior to the center of the ramus of the mandible, then it may injure the inferior alveolar nerve. The findings of the present study, MF-AB and MF-PB, were closer to the findings of Padmavati et al. And Shalini et al. Findings regarding MF-AG of our study were closer to the Gopal Krishnan et al. And Sultana et al. And findings of the MF-MN was closer to the August et al., Samantha et al. And Padmavati et al. The findings regarding MF-CP of the present study was closer to the Sultana et al. And the Sultana et al. was the only study that measured the MF-CP, but it was a South Indian study. Our study adds one more criteria, that is the MF-CP, means distance from the mandibular foramen to the tip of the coronoid process for the exact localization of the mandibular foramen, which was not done in the above North Indian studies. Our study findings may be dissimilar to the finding of the other studies done in the North Indian population because of the difference in the sample size and difference in the criteria taken for the measurement of various distances. Now, discussion of the shape of the lingula. Here, this table is created for the comparison of the other authors with the findings of the present study. And for the first time, Tully et al. Classified the lingular shape into the triangular, truncated, nodular, and asymmetric. Augut et al. Found mixed type of lingula in addition to the above. But the other authors mentioned in this table didn't find any mixed type of lingula in their study, just like the present study. Hussain et al. Didn't find nodular and mixed lingula both. All these variations may be due to the geographical differences. In our present study, we found truncated as the most common variant, but assimilated on the right side and triangular on the left side of the mandible as the least common variant, which was closer to the study done by the Kositbo Von Chai et al. And Padmavati et al. Here, table 7 is for showing the comparison of the incidence of the SSC mandibular foramina found in the other studies in relation to the findings of our present study. And here Only Asdullah et al. In the table 7 conducted a gender-wise study regarding the incidence of the accessory mandibular foramina and found more incidence in the female in comparison to the males. The incidence in the accessory mandibular foramina in our study was closer to the study done by the Shalini et al. And Singh et al. And in the Singh et al., they found the 39.29% of the incidence of the accessory mandibular foramina. And according to Shalini et al., they found the 32.36% of the incidence of the accessory mandibular foramina, and I also found the approx similar finding, that is the 36.67% incidence of the accessory mandibular foramina. And the future perspective of this study is future perspective of the study are imaging based validation such as the CBCT or CT scan and 3D analysis should be considered in future studies to increase sample size and more accurate measurements. The morphometric method to define the shape of the lingula can also increase the reliability of the study. A more diverse sample, including mandibles from other regions or ethnic groups, should be taken in future studies to strengthen the generalizability of the findings. Limitations of the study. A few limitations have been observed in the study. First, the sample size was less to determine the significant statistical test. Second, gender distribution was not performed due to already procured dry mandibles of unknown sex in department. Third, age-wise distribution was not done as previous data on the exact age of these procured mandibles was not available. Fourth, a limited geographic samples. Mandibles of North Indian origin may not fully represent the broader population's anatomical diversity. Conclusions. To achieve precise localization of the mandibular foramen, an additional parameter, the distance from the mandibular foramen to the tip of the coronoid process, can be helpful. The current study offers a reasonable understanding of the location of the mandibular foramen, the shape of the lingula, and the accessory mandibular foramen in the North Indian population, which will be helpful for maxillofacial surgeons, radiologists, and the oncologists for performing surgeries on the mandible. Additionally, the data can be helpful for the anthropological evaluations and reconstructive surgical procedures. These are the references of my present study, and thank you. Thank you very much.
That was a very insightful session. It's a matter of great pride for me to having been presenting in this international conference. So I am Dr. Mahima Sitaram. I am a maxillofacial surgeon working as an assistant professor at SRM KDCH, SRM IST. And I'm also an advisor at Impact, which is an organization that works towards wellness. And my interests are majorly towards craniomaxillofacial trauma. So getting into the subject proper, which is the role of oral veillonella species in predicting surgical site infections after maxillofacial trauma, which was a prospective observational study. This was a multidisciplinary project which was conducted as a multidisciplinary team which comprised of oral and maxillofacial surgeons, microbiologists, and of course oral pathologists and microbiologists in our institution itself. So when we talk about the oral cavity in general, we have salivary proteins, glycoproteins. It is an area which has so many microorganisms, and the tooth which are subjected to dental caries. We have periodontal diseases and worsening systemic diseases which are first seen in the oral cavity. So there's a process of sequential colonization wherein these glycoproteins and the microbiological species are often sequentially placed on top of each other, or there's an interaction between these two components that leads to various diseases. So here we are referring to saliva, which is a very easily available non-invasive biological marker, which we can also use for DNA, RNA, and protein analysis, and the microbiological species, more specifically referring to veillonella species, and more specifically veillonella parvula, which is most commonly associated with dental caries or periodontal conditions, and it is majorly present in the oral cavity. So it is said that of all the veillonella species, veillonella parvula or the veillonella species in general, close to 88% of these species are only restricted to the oral cavity. So we have literature wherein there have been multiple people from multiple eras, from multiple years, who have actually documented the presence of veillonella in terms of bacteremia, and it could be discitis,
monomicrobial veillonella species, which have been found in knees and hips in terms of prosthetic joint infections. There have been articles that have quoted that veillonella has been associated with osteomyelitis of the hip, and majorly were the oral species that were found in this region. They have also been associated with metastatic cancer, and this veillonella bacteremia has been said to exaggerate the said process. Also, Goes et al. In 2019 found out that this veillonella pavilla species, which is most commonly seen in the oral cavity, has been associated with vertebral osteomyelitis. So, because of this, we thought we could find out whether veillonella actually had a role in osteomyelitis, prosthetic joint infections, and septicemia, and we came up with identifying the species in the maxillofacial injuries. So because there has been history of isolating all of these organisms from osteomyelitis, prosthetic joint infections, and septicemia, also because saliva is a sensitive biological indicator, which is most commonly the area or the zone that contributes to the breeding of these microorganisms, the bridge for polymicrobial infections in terms of veillonella, affectation in open fractures, occurrence of sepsis, and its very fact that it's sensitive to ampicillin. And recently, there are multiple resistant strains of veillonella that have been identified, and no symptoms have been faced by the patients intraorally. We wanted to find out if all of this would actually be associated in maxillofacial injuries, traumas, and fractures. So, this led to an initial research question that we do refer to as hypothesis to find out whether if there is significant veillonella species in the patients who are presenting with the maxillofacial trauma, and even if we isolate these species or organisms, will there be a variation in the count in patients when they're intervened at different time periods? So we set two objectives for a study. The primary was to estimate the presence of veillonella in oral swab irrigation of patients who presented to with trauma. And the secondary was to assess if there's a difference in the number of these species with early, intermediate, and late surgical interventions. So this was a prospective observational study, and because we were initially venturing into this study, which was more of a pilot study, we set up a sample size of 30 individuals, and they were all subjects who were recruited from the Department of Oral and Maxillofacial Surgery in our institution, and we got an ethical committee approval. We included those individuals who are 18 to 70 years of age, patients who presented with trauma or fractures of the maxillofacial region, but with a varied time span of management, which I'll be explaining to you shortly. And also whoever had an anesthetic fitness of 1 and 2. Those patients who had no requirement of a surgical intervention or had already undergone some kind of a conservative management or a medical management or an antibiotic therapy were excluded. And those with debilitating diseases, referring to ASA 3 and 4, were also excluded from our study. So the steps, this is an overview of the steps. The participants were first assessed and an information sheet and a consent form was provided to them. We recorded all the demographic data and the trauma history. An intraoral swab and irrigation was taken on the day of admission, on the day of surgery, because we do initiate a preoperative antibiotic coverage for the patient, and also on day of discharge. And it was given for microbiological examination, which was done by subject experts, and the colonies were assessed and recorded. So this is just a picture of the participant information sheet and the consent form, which was provided in English and all other languages because the principal investigator of the study was myself. And having been well versed in various languages, it was easier for us to convey this to the patients who reported to the department or who were not well versed even in the language of English. So this was the evaluation form. We did a basic clinical assessment. We recorded the name, age, and the demographic details of the patient with the inpatient and outpatient number, any past medical history, the fracture type, sample taken time, and the intervention time, whether it was early, intermediate, or late. So when we refer to early, it means the patient has reported to us within 0 to 2 days of the maxillofacial trauma or injury, which requires an intervention. Intermediate, which means there has been a delay of about 3 days, 3 to 5 days, and post trauma of 3 to 5 days, the patient has presented to us. And late, which means for greater than 6 days, wherein the patient has reported to us after 6 days of the trauma or incidence, or there has been a delay in reporting of the patient because of the multivarious injuries in terms of a pan fracture for a pan facial or a pan fracture for the patient, or at the same time who were quite neglectful in coming for a maxillofacial trauma management. So the type of trauma, that was the fracture, was assessed and documented. A multidisciplinary approach is what we were targeting towards, and the time of surgical intervention was recorded as early, intermediate, and late, and as always, as I had already presented. And also those patients who presented to us with some kind of a suppuration or a surgical site infection due to negligence of not wanting to undergo a maxillofacial trauma management. So, as already mentioned, the saliva was taken on day of admission, day of surgical intervention, and the day of discharge. So what we did was a swab, that is normal saline, was taken intraorally. If it was difficult for for us to collect a swab, we had done an irrigation of normal saline and then collected the salivary flow. It was an unstimulated saliva that was collected. It was taken in 3 vials, so that was sent for microbiological analysis. The 3 vials refers to the time periods that this saliva was taken. It was on the day of admission, on the day of surgery, and on the day of discharge. So we did collect all of this saliva in a sterile Eppendorf tube, mixed it and centrifuged it with a sterile saline to remove all the supernatant, all the cell debris. It was then vortexed for about 10 seconds and then stored in -80, which was then sent across for a brain heart infusion broth for 7 days and a veillonella blood agar for 5 days. Once the growth was obtained on these plates, we had then taken it, as you can see to the left, there's a Macintosh field jar in which we did an anaerobic culture. And also the colony count was assessed using Vitek 2 cards. This was done by a microbiological subject expert. So here we can see the results that if we talk about the age, the mean age was about 54, and majorly were male patients who presented to us in the department. If you can see, I would like to direct your attention to the median amount of the veillonella species that we saw in early, intermediate, and late. You can see a gradual decrease in the veillonella parvula colony count in these patients, which was recorded in colony forming units per ml. So this was done for early, intermediate, as you can see the reduction in the colony count, and late. So I also referred to the population who presented to us with surgical site infections and also osteomyelitis, which was for greater than 10 days. So when they reported to our department, we did collect the saliva and sent across for the microbiological analysis. And you can very well see the difference in the microbiological culture in CFU per ml on the day of admission, on the day of surgery, the day of discharge, and of course the POD10, which was collected for these patients who presented with a surgical site infection. So if we do project it onto a graph, you can very well appreciate the reduction in the colony count. And I would like to direct your attention to the surgical site infections, which actually saw a very varied reduction in the colony forming units per ml of this veillonella species. And this was one interesting finding that we had in our study. We saw that as the veillonella count kept increasing, the Streptococcus salivarius count kept reducing, and the Streptococcus mutans count kept increasing. So they say in literature there are a few articles which quote the relation between Strep salivarius and Strep mutans, because Strep salivarius is said to be more of a biological protecting microorganism, and mutants is said to be an impeding factor onto the protecting mechanism, which often goes around to dental caries and other oral infections. So this was one interesting finding that we saw in our study. So I would like to show that this was the culture plate that we had done for veillonella agar, blood agar, microscopic view of veillonella, and the identification of Strep salivarius and Strep mutans, and the microbiological view along the microscope. So the implication of the study is indicating and indicating that there's a possibility that this microbiological species, that is veillonella, which is most commonly seen in the oral region or in the oral cavity, which has been probably as a factor in maxillofacial surgical site infections owing to the heavy colony count that we saw in patients who presented with surgical site infections. Second, the role and interaction of these microorganisms, and of course the other oral microbiota, which has been exhibited in the study. Also, third, this could also prove to be an awareness factor wherein, be it dental surgeons, be it ENT surgeons, any surgeon who is who is examining the patient intraorally can identify the probability or the presence of a surgical site infection in a particular patient if we can probably guide them in terms of investigation and modify the treatment schedule and protocol. This can also help us in identifying and motivating the patient to undergo appropriate oral examination oral any treatments required intraorally, and also motivate the patient that treatment of a maxillofacial trauma is as important as it is for other fractures and other trauma. So the limitations of our study was first the geographical variation, because majority of the patients who were recruited in our study were from southern Indian population. The sample size, of course, we have been working on it, and we are trying to take it in a multidisciplinary and a multi geographical pattern analysis. And a lack of literature, because there are not many articles in terms of there are only case reports or very few case control studies that talk about this relation. We do not have much of randomized control trials or some kind of systematic review that would help us in identifying the role of the species. And of course, other branches of intervention we could not classify, because these patients presented to our OPD with the maxillofacial trauma. So, assessing whether other interventions have been provided to the patient apart from the history that the patient reported to us with, or with the summary that the patient reported to us with, we could not assess the other branches of intervention or classify them. So the reasoning for this study is that first, when we deal with a maxillofacial trauma or with trauma in general, it is a multidisciplinary approach. It cannot just be by one field. There have to be many medical, dental, all departments together who would work just to ensure that the patient has some amount of benefit. Next is the importance of the facial trauma management and assessment, which is very important, and of course, treatment. Third would be referral. So referral in terms of an interdisciplinary coordination between the dental and the medical fields, continuous assessment of the oral health status for such patients, and of course, motivating the patients for early management and hospitalization, wherein we do see the dropout rates from our hospital, which are increasingly exceedingly high even in the South Indian population, even though the patient might feel they are medically stable. So these are my references. Thank you so much. Of course, it would be wrong if I don't thank the entire team of the International Conference of ENT Head and Neck Surgery for providing an opportunity to me for presenting my original research. Of course, my institutions, which is SRMIST Chennai and Impact, who have been always motivating factors for us to carry out all our original research projects in full force. So that is from my end. Thank you so much.
Thank you.
From Mahindra University, Hyderabad, India. So today I'm going to talk about the title Speech Language Outcomes in Telugu speaking children with cochlear implants. So basically, this presentation explores the impact of cochlear implants on speech and language development in Telugu speaking children with severe hearing loss. So especially we took this study as a pilot in region of Hyderabad, India, where later probably we can implement this study in other states as well. So this study mainly focuses on early implantation and auditory verbal therapy to understand the rehabilitation effectiveness in linguistic groups, especially a large linguistic diversity in India. So we wanted to understand what kind of rehabilitation effectiveness in the linguistic groups across the states post cochlear implantation in children. So coming to the introduction of this study, basically cochlear implants are transformative interventions. So basically, what are the cochlear implants? They bypass the damaged cochlear hair cells by converting sound into electrical impulses, and they enable profoundly hearing impaired children to access the processed speech. And the benefits of these cochlear implants are improved speech perception, music appreciation, and auditory learning. And why assessing speech and language outcomes in post cochlear implant surgeries? To quantify the success, the standardized measures like CAP, SIR, and RDL track process over time, and guide therapy, basically a data-driven insights, tailored a post-implant auditory verbal therapy, and inform best practices. The outcomes basically refines the candidacy criteria and rehabilitation process, and the support holistic development, basically a strong communication skills, highlight academic, social, and economical well-being of the children. So coming to the background of this study, the prevalence of hearing impairment in children is basically a global burden. So over 34 million children worldwide have, disabling hearing loss, including, one per three in 1,000 lives birth. Coming to the Indian context, the estimate suggests that 6 to 8 per 1,000 children are born with, moderate to profound sensorial losses. So the factors including genetic syndromes, neonatal infections, and ototoxic medications. So early detection gap, yes, there is a huge early detection gap. Universal newborn hearing screening coverage remains on under 50% in many regions, delaying interventions and language development. So, what is the role of cochlear implantation in auditory rehabilitation? Is basically a bypassing damaged cochlea and restoring access to speech and multidisciplinary care and long-term benefits like it demonstrate the improvements in speech discrimination, sound localization, and social integration when implanted before the age of 5. So, what is the rationale behind this study? Is need for a language-specific research in Telugu speaking population, where the distinct phonological profile, especially Telugu's vowel length contrast and retroflex consonants and syllable structure differ markedly, from Indo-European languages. So the dialectal variations, if you see, there are many dialectal variations. The mainly, if you point out in Telugu regions, the coastal Rayalaseema and Telangana dialectal variations. And the assessment gap is, few standardized outcome measures exist in Telugu. So in reliance on English tools risk the misestimating children's true abilities. So the evidence for best practices is that language-specific data are essential for, to refine the candidacy criteria and therapy goals and, timeline recommendations post-therapy of the cochlear implantation. So coming to the cultural and linguistic aspect of the therapy, the family language development, where Telugu is often used at home and in community settings, where therapy must align with the naturalistic communication context, and culturally relevant material should be incorporated. A community attitude should, understand the socio-cultural beliefs around disability guides and therapist training. Speech language professionals requires a proficiency in Telugu phonetics, prosody, and pragmatics that delivers the effective AVT tests. So coming to this objectives of this study, the main objective is to evaluate the speech intelligibility post implant. So basically to quantify the clarity and accuracy of the spoken out output using the speech intelligibility rating test. It is called SIR, and blinded listener judgments will be done by the professional audiologists. And the second objective is to assess the per- perceptive and expressive language skills. Basically, here we measured the comprehension and production with the RDLS test to chart the age-appropriate progress. And the third objective was to examine the impact of early implantation and AVT. So basically, here we compare the outcomes of children implanted before the age of 3 versus later after the age of 3, and the analysis of the effect of AVT duration and intensity on the speech language gains. So coming to the overview of the participants, there were 50 Telugu speaking children aged between 3 to 12 with prelingual hearing impairments and cochlear implants used for at least 18 months post surgery. And the implantation age, all the children received the implantation before 5, with focus on early implantation benefits. And the research design was mixed methods approach, combined qualitative assessments and the quantitative interviews. The assessment tools used in this study were the category of auditory performance, that's called CAP, the speech intelligibility rating test, SAR, and renal development language scales to decide the age. So the qualitative feedback, the structured interviews with the parents and speech language therapists to assess the real life communication in social integration. So coming to the data collection, the qualitative data assessment was administered in a standardized test like CAPSIR and RNDLS at 6 months and 18 months post implant intervals, and scored by certified audiologists and speech language pathologists. And the structured interviews, qualitative data is again a semi-structured interview, parents and captured home language use where their native language children used in Telugu. So basically the qualitative data was structured interviews with the parents. So coming to the speech intelligibility outcomes, if you see the high speech intelligibility, so there are 78% of children that achieve the moderate to high speech intelligibility levels. So if you see the early implant advantage, children implanted before the age of 3 showed a significant, better speech clearly. If you see the significance 0.001, so the key skills are improved phoneme discrimination, spontaneous sentence generation, and conversational turn taking. These are the skills that are. So if you see the bar graph representation of overall speech and language outcomes, if you see the speech intelligibility test, there's significantly 78% of the improved results if you can see. And if you see the receptive language for a near age, it's nearly 68%. Coming to the language development outcomes, the receptive skills and expressive skills, again, the 62% of children reached the near age appropriate language levels in both receptive and expressive domains. So the impact of early implantation is that the earlier implantation, correlated with the stronger language development across all measures. So the therapy importance is that the consistent auditory verbal therapy, that accelerated language acquisition. So if you see the representation of language outcomes by AVT tests, consistency, 78% and 2%. And if you see the heat map percentages of overall language outcomes, pre and post therapies. So the role of auditory verbal therapies, if you see the structures and interventions, the AVT provides the systematic auditory and speech training post implantation, and the consistent sessions, regular therapy sessions, like to faster and better language outcomes. And the cultural relevance is that therapy adopted to Telugu language and the cultural context enhances the effectiveness. Where since this is just the pilot for one region, probably will extend it to initially south, and then probably will extend it to north as well. So the parental and therapist perspective, if you see the parental involvement, the active participation in therapy, supports the communicative development. If you see the therapist insights, the professional highlight the need for regionally adapted therapy models. And if you see the social integration, improved communication skills, aid children's inclusion in social settings. So implications for the rehabilitation, if you see the early implantation, the critical for maximizing speech and language outcomes. If there is no early implantation, then there would be, a very critical for language outcome. So if you see the customized therapy, there is a need for local language assessment tools and culturally sensitive approaches. So the main reason to use the local language approach is because the child starts to acquire their mother tongue effectively rather than the second languages. So developing the tests in local language is very important in these aspects. And coming to the parental roles, it is essential for reinforcing therapy and supporting language growth in children. So the key takeaways and the future directions would be early cochlear implantation with AVT leads to substantial speech and language gains, and the regional adaptation therapy models and parental involvement are vital for success. If anyone that neglects these aspects, then there will be a child losing the language. So the future research should focus on the developing local language tools and expanding access to early intervention in cochlear implantation surgeries using the AVT test. So thank you. If you have any questions, probably you can ask.
Hospital, Saudi board certified doctor. I would like to thank the scientific committee for accepting our paper and the organizing committee for such an amazing organization. Today, our talk will be about our recent systematic review that has been published, titled as Efficacy and Safety of Platelet-Rich Fibrin Combined with Diced Cartilage and Rhinoplasty, a systematic review and meta-analysis. Those are the co-author in the study. Our study was recently published in the European Archives of Otorhinolaryngology. I advise you all, and then I invite you all to go and read it. It was a systematic review and meta-analysis, as I mentioned, about the efficacy and the safety of the combining the platelet-rich fibrin with the diced cartilage in the rhinoplasty. All the author declared there was no conflict of interest or any financial support while conducting this study. The ethical approval we guaranteed from Bisha College in southern region of Saudi Arabia. The data was used in this study were obtained from the databases, such as no individualized informed consent was required. And of course, all the procedure in the study were conducted in approved protocol in Bisha College. There was no violation of human rights. This is our abstract. The diced cartilage, as we know, it's a usually common technique in rhinoplasty. Recently, some authors and some doctors, they added the platelet fibrin technique to increase the cartilage viability. So we were comparing the diced cartilage technique in the patient rhinoplasty and the patient who added the platelet-rich fibrin to increase the cartilage viability in post-op period in the rhinoplasty. Rhinoplasty ranks among the most performed operation, as we know, in facial plastic surgery. In addition to rhinoplasty, is a challenging procedure owing the complex anatomy and the relationship among the tissue in the different nasal regions. As we know, one of the most common complications following rhinoplasty is the development of the nasal dorsum. Some people, they would have irregularities, especially after a large surgery of open rhinoplasty, especially in thin skin or some females. When these irregularities are visible or palpable, it can reduce the patient's satisfaction and require to perform a revision or second rhinoplasty. To overcome the problem of the bone resorption after diced cartilage, the research evaluated combining and wrapping the cartilage with the material of the rich fibrin to prevent the resorption of the diced cartilage and to give further stabilization in the post-op period. Our aim and the purpose of the study was to see the resorption of the diced cartilage and the appearance of the irregularities on the nasal dorsum or tip post-op. Post-operative complication like edema, hematoma, infection, erythema, displacement, extrusion of the cartilage, and the patient satisfaction in both arms, patient who were only using a diced cartilage and a patient with diced cartilage and the high rich fibrin formula. The method, of course, the systematic review and the meta-analysis were registered in the International Prospective Register of the Systematic Review. This study was conducted following the principles of the Cochrane Handbook of Systematic Review of Intervention, version 6. The type of the study were included in the study, observational studies and clinical trials that were published in English language and from the inception until 9th of August 2024. We compare and we included both single arm studies and the studies comparing only the platelet-rich fibrin with the diced cartilage or the diced cartilage alone. Our inclusion criteria, patient who undergoing rhinoplasty with using the platelet-rich fibrin with diced cartilage. The exclusion criteria were we excluded abstract, duplicated record, case report, review articles, editorial, and so on. The data synthesis we used and we analyzed the data using the statistical language version 404. The incidence of each outcome were calculated using the inversion variance method on the intra-transformed proportion with 90% CI confidence interval for the individualized studies. The continuity correction was applied to the study with 0 self-frequencies in case of significant heterogeneity. The forest plot, of course, we use it to create forest results pooling and the pooled incidence. And the formal testing of application bias was not performed as the number of the included study were less than 10 trials, which is 7 trials. As a result, we calculated almost, if you see here in the picture, 103 studies in the database. We're talking about the platelet-rich fibrin and the diced cartilage. From those studies, we only included 7 studies, in total of 286 participants, and the results showed a little resorption of the cartilage included in 5 studies. The pooled incidence rate of the dorsal tip irregularities, erythema, and the displacement were 0.4% in 6 studies. and the bold incidence for the satisfaction rate was 94% in 3 of the studies. So the characteristic or basic characteristic of the included 7 studies, as you see here, the location of the study, most of the study were in Europe, North America, Southern America. There was no or almost none studies in the Middle East or Asia. The top number of the study or the sample size was in the Pollock et al. 2011. He included 68 patients. It was a randomized control single-armed study. The second next large sample was in a study done in Mexico, 2015, Gastrogovia. He also included a single-arm randomized control trial study. They followed most of the studies. They followed the patient for 1 year and 1.5 years. The longest period of follow-up were in the Gastrogovia, the study that was conducted in Mexico, 2015. The baseline criteria and the included studies, the larger number of the sample was 68, as we mentioned in the Pollock et al. But unfortunately, in his study, he didn't focus on the age or the gender variation. He didn't mention about the female gender or the age that were used in the study. Also, he didn't mention about the status of the skin of the patient. Was it a thin skin, or did they do any secondary or revision rhinoplasty for the patient later on? In his arm, he did both technique, diced cartilage with the fibrin sheet coverage over the diced cartilage. The Gastrogova et al., he also did the same technique, diced cartilage with the fibrin-rich. He mentioned that his study was like 80% or 75% of his study were female, and a quarter of his patients, they needed a secondary revision rhinoplasty. If you see the age variation, usually it's from the 20-30s age group of the patient who did a rhinoplasty, and only 3 studies they did for their patient a secondary revision rhinoplasty, which was the Gastrogova and the Kovac et al. And NATO et al. In 2020. Regarding the resorption of the cartilage and the irregularities of the skin, the patient satisfaction in the 7 studies, the best study in the satisfaction score was recorded by Gastrogova Mexico study. He recorded 91% satisfied patient post-op, and only 4 from 45 patients included in his study, they needed a secondary revision rhinoplasty. For the volume, also his study conducted a good score in 88%, an excellent result of the non-resorption of the cartilage. He used both technique, the diced cartilage and the fibrin-rich technique. The rest of the study, as we see in the Mohibi et al., he used two-arm technique. Half of the patient, they used both technique, and the other half diced cartilage. And as we see, the volume loss was more in the diced cartilage alone without using the platelet-rich fibrin. In the post-operative complication, in the included studies, we talked about the erythema, hematoma, edema, infection, and displacement. Again, in the Pollock et al., he commented that 11 of his patients had erythema, but none other had infection or displacement. Also for the Gastrogovia et al., he had only 1 patient with displacement and exclusion. The rest of his patients were okay. The Mohibi et al., he did not comment about the complication in both arms, either diced or platelet-rich fibrin. So the result of the presenting systematic review and the meta-analysis is established for both the platelet-rich fibrin and the diced cartilage rhinoplasty associated with favorable postoperative outcomes. However, only 3 studies contained a control group that underwent diced cartilage alone, as we mentioned. We were unable to conduct a comparison in the meta-analysis between the 2 groups. Comparative studies are required ascertain whether using the platelet-rich fibrin or the diced cartilage provide clinically significant benefit compared to the using the diced cartilage alone. In addition, the length of the follow-up was short in most of the studies. As we mentioned, only in the Mexico study, they had a longer follow-up period for 2 years, which this limits the evaluation of the reliability of the long-term aesthetic outcomes of the diced cartilage. Moreover, the included study showed a varying grade of the bias, which ranged from uncertain to high. All these factors can downgrade the evidence and they indicate of the presence of the knowledge gap that required further high-quality randomized controlled clinical trials. In conclusion, we conclude that the addition of the platelet-rich fibrin to the diced cartilage was associated with favorable post-op outcomes and excellent patient satisfaction, as we saw in one of the studies. The incidence of the adverse effect was very low in the combination technique. However, there is a paucity of the comparative studies to confirm whether the outcomes after using the platelet-rich fibrin are markedly better compared to the diced cartilage alone. Randomized controlled clinical studies are warranted with a large sample size and adequate follow-up duration. So we need a larger sample, as we saw only one study, they had a good quantity of patients. And we need a longer follow-up duration, like 3 to 4 years, because the longest was only 2 years. And to compare again the diced cartilage alone with the combination technique, because most of the studies, they did only single arm combination. Only one study compared both the diced cartilage and the combination technique. Those are my references, and thank you.
Thank you so much, Dr. Salma.
A practicing head and neck oncologic surgery surgeon. So today my topic is about assessment of vocal cord function using transcutaneous laryngeal ultrasound, a tertiary government hospital experience, along with my co-authors. So we will start. So visualization of the larynx is, we usually use a rigid laryngoscopy as our main choice or gold standard to assess the laryngeal function. And flexible transnasal endoscopy and rigid laryngoscopy is the tool of choice. But during the pandemic, these procedures are said to be aerosol-generated procedures. So our institution sought other modality to assess the vocal cord function as a assessment of our preoperative thyroid patients. So there's really a lot of application of ultrasound already in ENT, since it is non-invasive, relatively inexpensive, and radiation-free, and well tolerated by patient. We already use it as a guiding needle biopsy, for thyroid nodule, lymph node, or even for alcohol ablation and radiofrequency ablation. We can also use it as a guide for endotracheal tube placement and pre-operational assessment of flap vascular supply. And in our institution, we also use it as a core needle biopsy guide for our laryngeal mass, who these are for patients who cannot undergo general anesthesia due to high risk status preoperatively. So
Now, we use the high-resolution ultrasound as an alternative tool to assess the laryngeal motion. According to Carneo et al., detection of laryngeal motion abnormality using TLUS, it has actually a sensitivity of 93.3% and specificity of 97.8%. In this study, the one who performed the ultrasound is the radiologist. And during the pandemic, we were thinking, since we already applied ultrasound in our ENT practice so much, why don't we use it also as a tool for us surgeons to perform the laryngeal assessment? And this is specifically to emphasize the surgeon perform transcutaneous laryngeal ultrasound in assessment of vocal cord function as an alternative tool, as an alternative to rigid laryngoscopy. And we have the specific objective to describe the method, the maneuver, and to describe the utility of TLUS as an alternative to laryngoscopy for oral HNS practitioners. So this is a prospective observational cohort study in a tertiary government hospital. All thyroid patients who we see in the head and neck clinic in our institution, age and are included in this study, whether the patient have benign or malignant thyroid disease, and our population is 19 to 68 years old. And all patients underwent video laryngoscopy. The video laryngoscopy is performed by the resident in our institution, also ENT, and the transcutaneous laryngeal ultrasound is performed by one surgeon, me. So once the transcutaneous laryngeal ultrasound is performed, it's actually recorded into videos. Each patient will have 10 seconds of videos and a video of a laryngoscope as well. And this I will show you how we perform the transcutaneous laryngeal ultrasound. So tips on performing this is the transducer should be positioned in the middle or inferior to the thyroid cartilage, so you can palpate that, and then angulate obliquely upward 45 degrees. And you should instruct the patient to do quiet breathing, he, or dry cough. So I'll play the video how we perform it. Effective deangulation. Okay. And then you ask the patient to say he. So you can see the vocal cord mobility is actually very visible. From our experience, it's easier to secure the view in the ultrasound if you ask patient to do dry cough instead of he, because when you ask the patient to phonate, usually the thyroid cartilage will be tilted inferiorly, so it will obstruct your view. So better to instruct the patient to do dry cough. So this is our patient profile. We have 26 patients included in the study, 25 females and 1 male, and the mean age is 42.5%. And in this study, there are 6 out of 26 patients have pathologic vocal cord motion on rigid laryngoscopy. So the videos of the laryngoscopy videos and then the transcutaneous ultrasound videos, they're presented to 4 ENT practitioners. So these ENT practitioners, or in our study, we call them readers, range from resident, young consultant, head and neck fellow, and consultant in ENT who already practice several years. And then we ask them to identify in the video, the ultrasound video, if they can identify the vocal cord, if it's equally mobile, if it's paretic, pathologic, or paralyzed. So this is just a video that's presented to our readers, and I would want the audience to try to view also from the videos if you can detect which among these 4 videos have the pathologic vocal cord movement. So you can see. So the video is only 10 seconds in this study. So the answer is actually letter C. There is paralysis on the right vocal cord. As you can see here, it's not moving. So this is the corresponding laryngoscopy of the patient. So transcutaneous ultrasound, in our study, we actually have the sensitivity of 91.6% and specificity of 95.1% on detecting a vocal cord abnormality, whether it's paralyzed or paretic. So it may serve as reliable alternative screening tool for ENT practitioner in assessing vocal cord mobility in thyroid patient. So when you compare in the study, if it's paretic or paralyzed, the paralyzed have a greater specificity compared to the paretic vocal cords, because sometimes in the ultrasound, there may be perceived movement, but it's actually not. They will read it as paretic, but it's actually paralyzed. But as you can see, the specificity is still very promising. So the ultrasound is highly operation dependent. And then in our study, it's only 10 seconds to for them to assess. So if you do real time, the specificity and sensitivity will increase. And it requires not the accuracy rate of detecting the pathology. It does not translate to the time of practice in ENT, but translate to the using of TLUS in assessing vocal cord mobility. So the more you do the ultrasound, your accuracy will increase, even if you're just a resident. So real-time examination, as mentioned a while ago, will increase your accuracy rate. And then when we interviewed our patient who undergo this TLUS, they all said the comfort level is better than when we do the laryngoscope to them. So in conclusion, TLUS may serve as a reliable alternative screening tool for oral health practitioner, and it can be used to differentiate the paralyzed and paretic vocal cord, but acquisition is highly operational dependent. So this is a paretic, just to give you a comparison. So see, in the left vocal cord, there's still movement, but when you compare it to the right, you can see there is a difference. There's movement, but not equal. So this is a paretic vocal cord, and it is confirmed with our laryngoscope findings. So this is my reference. And this journal is actually published already. So you can access the journal through this QR code. And that ends my presentation. Thank you for listening.
Thank you so much, Dr. Justin. And the chat box is open for question and answer.
Alveolar nerve bypass during tilted implant insertion, a 3-year retrospective cohort study. This work explores a minimally invasive solution for rehabilitating atrophic mandibles, and I'm excited to share the findings with you.
I'm sorry to interrupt you, Dr. Nadeem, but can you make your screen full screen?
Okay.
Yes.
Okay.
Can you switch on the slide share mode so we can see your current slide?
Okay. Is it okay right now?
Yes, yes, you can go ahead, no problem.
Okay. Is it okay?
There is on top, you have the slideshow. If you can click on that.
Okay, that's fine.
Not yet.
I'm sorry. Just a little bit. Is it showing the presentation right now?
It's okay. We can see. You can go ahead. No problem.
Okay. Okay. What's the challenge? What's the challenge for us in atrophic mandibles? Let's start with the problem we aim to address. As we know, placing implants in the atrophic posterior mandible is challenging due to insufficient bone volume. Conventionally, this requires bone grafting procedures that are maybe invasive, time-consuming, costly, and not always feasible due to patient-specific contraindications. Is it showing right now the third slide? Okay. Let's talk about the background. Let's discuss the challenges. Progressive bone resorption severely limits implant options. Current solutions like guided bone regeneration, or let's say GBR, or distraction osteogenesis, come with considerable morbidity and complication rates. Tilted implants offer a viable alternative by allowing us to bypass the inferior alveolar nerve. This approach can potentially increase the bone implant contact surface and maybe give us the primary stability that we need without any need for bone augmentation. So we are talking about less invasive procedures, shorter treatment duration, and is appropriate for patients who have contraindications for bone grafting. Let's say the bad oral hygiene index, or maybe the lack of soft tissue for coverage of the grafted area. To talk about the study design, for the methodology, retrospective. This is a retrospective cohort study. It consisted 26 patients. We inserted 31 implants in atrophic mandibles. The patients had a Coward and Howell classification 6. So we are talking about depressed bone level. To talk about the key considerations, careful planning and execution are of paramount importance when bypassing the inferior alveolar nerve, which is the most commonly injured during our oral surgery practice. Preoperative planning consisted a cone-beam computed tomography scan, which is essential to accurately evaluate the inferior alveolar nerve position and residual bone volume and density. We aimed always in our practice for this study for a minimum of 6 millimeter of bone width adjacent to the inferior alveolar nerve and implemented a 2 millimeter safety margin during the drilling process. To talk about the anesthesia, buccal and lingual infiltrative local anesthesia was utilized with epinephrine. This is critical to maintain the sensorial feedback of the patient while drilling near the inferior alveolar nerve. This is a very important point. The patient feedback, specifically any pain sensed, is carefully noted during the drilling phase. A full thickness flap is raised to ensure the complete visual of the alveolar bone, because it's our only guidance throughout this process. Drilling begins with a pointer drill to access the bone, to access the cortical bone. After that, we use the pilot drill. We use a maximum speed of 400 RPM with good irrigation to prevent potential thermal injury to the inferior alveolar nerve. To talk about the angulation and the specific direction of the drilling during our practice, our procedure. This is an unguided technique. The drill is positioned either buccally or lingually based upon the plan, aiming to keep the drill parallel to the respective cortical plate that we are dealing with. So if we are going to put our implant buccally, so we follow the buccal plate. And if we are going to put it lingually to the inferior alveolar nerve, we follow the lingual plate. During the drilling process, in and out motions with light pressure are employed during the implant site preparation, paying close attention to any patient pain reflexes. Despite critical assessment and planning, direct mechanical injury may happen during our procedure, especially in low bone density, where the drill may slip because of the low density of the alveolar bone that we are dealing with in posterior mandible. So a 2 millimeter plant margin is implemented for such cases. To talk about the study design and the methodology, sorry, I'm talking about the key results. Okay, in our study, there were 31 implants inserted in 26 patients. The results were highly encouraging. First of all, the survival rate was 100% over the 36 months. This is a 3-year retrospective cohort with no implant failures. Nevertheless, 3 patients experienced temporary neurosensory disturbances, but all resolved within 3 weeks. Soft tissue impaction also occurred in 7 patients, all buccally tilted implants. So it happened that the soft tissue impacted buccally to the buccally tilted implant. This was easily managed with customized abutments. Actually, the low bone density correlated significantly with neurosensory risk, underscoring the need for careful site selection and careful case that we choose to do because the low density is actually a danger, maybe dangerous to put an implant in D4 bone. So we have to be very proficient and very attentive to the implant insertion. Talking about the clinical implications, what does this practice mean for us? Tilted implants offer clear advantages. As we said, they avoid grafting and reduce patient morbidity, and we may actually increase acceptance by shortening the treatment time. However, it needs a precise reading and planning of the CBCT that is conducted before the procedure to assess the bone density and the nerve position, so we direct our drilling precisely. A negative point for this study that it needs a surgical skill to execute for the angulation safely. For doctors considering this technique, please prioritize patients with adequate bone width and avoid low density sites when possible. Let's talk about our limitations. For this study, of course, it has limitations. The small sample size. This is a precise procedure, so actually we always tell the patient that we have some dangers, some complications may happen. So not all the patients gave us a consent to be a participant in this study. So it was a small sample size. We had no control group and a relatively short follow-up. Future research should explore long-term marginal bone loss and the role of surgical guides to enhance the precision. Actually, some say that you need to use the surgical guide because it's better and it's more accurate and safer. There is a negative point about the surgical guide that it has a limited flexibility intraoperatively. There is an access challenges in posterior mandibles with limited mouth opening, so we don't have the height and the distance enough to put our drill in the precise direction. This procedure is very precise, and we have to put the drilling very accurately. So bulky guides may obstruct our instrumentation. In conclusion, the use of tilted implants present a predictable and viable option for patients with atrophic posterior mandibles. Bypassing the inferior alveolar nerve without necessarily requiring extensive bone augmentation procedures is a positive point, while temporary disturbances, neurosensory disturbances may occur, particularly in lower bone density. Careful preoperative CBCT planning and designing the plan for this accurate procedure and strict attention to the surgical technique may give us a great result. Okay, what is our takeaway? Actually, meticulous planning and technical proficiency are non-negotiable to optimize outcomes for this specific practice. Thank you for your attention. I'd be happy to address any questions. Thank you.
Thank you so much, Dr. Nadeem, for your insightful presentation. Thank you for
just be presenting an interesting case report, a rare occurrence between CVST and, interestingly, varicella infection. It's quite a rare complication, CVST in itself, let alone being associated with varicella infection. And sometimes there might be a slight overlap between CVST and some of the common ENT conditions, such as the otitis media or mastoiditis. So just being able to have a clear picture of those early signs, I think, is quite important. So just before we dive into the case itself, I'd like to just very briefly touch on CVST in itself, cerebrovenous sinus thrombosis. And it's a rare form of stroke, essentially, where a clot is formed in the venous sinuses, in the cerebral veins, and this can lead to impaired venous drainage, rising the intracranial pressure, and it can lead to infarctions and hemorrhage and quite serious complications. And as we mentioned, it's quite a rare form of stroke, making between 0.5 to 3% of strokes, and it predominantly affects the middle-aged younger individuals, on average about 55 years of age, and with a slightly female to male predominance. Now, when it presents, it can present non-specifically initially, with headache being the most common presenting feature. Also visual disturbances, dizziness as well. And if it's a bit delayed, then you can have quite serious presentations such as seizures and focal neurological deficits with it as well. And it can be due to secondary causes such as infections, trauma as well, any hypercoagulable state, and that's what we'll touch on in the case report, or any systemic inflammatory states can really trigger CVST. The way we diagnose it is gold standard way by MR venography, or CT venography. Both are quite sensitive and specific for CVST. And treatment involves anticoagulation, so long-term anticoagulation with regular follow-up and re-imaging, just to see how it's resolving. Interestingly, compared to other conditions, if sometimes there's a bleed, you actually tend to still anticoagulate cerebrovenous sinus thrombosis, mainly because any bleeds picked up with this condition are usually secondary to the thrombosis. So managing the thrombosis will manage or resolve the bleeding. So it's one of those situations where if you do see a bleed, we still anticoagulate. And prognosis-wise, it's generally quite good. Early recognition is important, and patients do recover quite well. The only issue can be in delaying diagnosis, because if that's the case, then quite often it can be quite fatal. So just a very quick touch on the basic anatomy of the cerebral veins and the sinuses. This is just a more simplified image that I could find, and it just highlights the common sinuses and veins that are affected. So the most common one is the big one, which is the superior sagittal sinus, which is just at the top between the two hemispheres. And then on the sides, just at the base and above the the cerebellum, is where we have our transverse sinus, and that's the second most commonly affected site, and then followed by the straight sinus, which is the one that connects the superior sagittal sinus and the inferior sagittal sinus at the base. And then finally, we've got the internal jugular veins, which are at the bottom. And then multiple sinuses. It's where you have a number of sinuses that are affected at the same time. That's also quite common. It can make up anywhere between 18 to 50% of the cases that are seen, as we'll show now in our case report. So the reason I've decided to include this case report today is because whilst CVST is an unlikely complication of our usual ENT conditions and infections, being aware that sometimes there might be an ever so slight overlap, mainly this is from the anatomical proximity of the sigmoid and the transverse sinuses. They're very, very close to the middle ear and the mastoid air cells as well. So if there's an infection there, then it could potentially spread and involve the sinuses. And it can be either by the emissary veins or bone erosion in the case of mastoiditis, where it can just spread directly and involve some of the other sinuses, lateral sinus thrombosis. Some of the red flags that we should keep in the back of our minds when we're dealing with, say, things like mastoiditis, or even in rare cases, otitis media, once we get an inclusion of things like a persistent headache in the background, or dizziness associated with these infections, or even visual disturbances as well, it should get us thinking into whether or not there might be something else going on, or if the current infection or condition has spread and there might be other structures involved as well. So it's just important to keep in the back of our minds. Those most commonly at risk are children and immunocompromised adults. So it's important to have a low threshold just to investigate it a bit more. And if left untreated, we can have serious complications, such as infarctions, seizures, or even death if left untreated. So I'll just very briefly now touch on the case report that I came across not too long ago, where we had a 38-year-old gentleman who presented with quite severe headache, presenting 3 days prior to admission. Nothing very remarkable in his presentation, no visual symptoms, his speech was fine. Romberg test was negative, he wasn't dizzy, ever so slight nausea, and he did have pain on the left temporal side, and then involving the occipital area in his neck. He did say he had some oral fullness as well. No vertigo or hearing loss, and no seizures were reported as well. An interesting thing, we did note that the patient had a rash which started about 4 days prior to his admission. So at this time, we've got severe headache, some oral fullness, and a rash which started about 2 weeks ago. Now, on examining the patient, he did have quite widespread maculopapular lesions involving his arms, his trunks, and thighs, and they were crusted at the time. So at that point, it was quite characteristic that he did have recent varicella infection, chickenpox. Clinically, he looked quite well with a normal GCS. His neurological examination was fine. Otoscopy was normal. It didn't show anything. Warnberg was negative. His fundoscopy was fine as well. And no signs of any meningeal, any meningism, or any mastoid tenderness. His bloods were more or less normal. Nothing was standing out quite significantly apart from his ALT, which is a bit raised. And observation-wise, he was quite stable hemodynamically speaking. So we proceeded to do a normal CT scan. I'll just show you here. And so we can see from the CT scan that around the occipital area, we've got a sort of a hyperdensity in the back there. Now, as we said earlier, usually a venogram is the best way to assess for CVST. However, your normal CT sometimes can show you some signs like the hyperdensities in the areas corresponding to the sinuses. It's not very specific, but it is important to investigate it further and see what's causing these hyperdensities. We went on and performed the CT venogram, and to our surprise, he had quite extensive occlusive left transverse and sigmoid sinus. So both sinuses were involved and thrombosed. And then we've done an MRV as well, just for better characterization. And we saw even a further extension into the left jugular vein. So we can just go back to this slide here, to the anatomy. We can see from the sigmoid, the transverse, and going all the way down into the internal jugular veins, all of that was thrombosed quite severely. So treatment involved low molecular weight heparin initially, and then warfarin. We still cover these CVST with warfarin, and we just bridge it with low molecular weight heparin, and his headache did improve quite significantly after that. And because it needs long-term follow-up, the patient is followed up under help from the hematology team. And then a couple of months later, he was rescanned, and he did show improvement in his CVST. And all of his other symptoms resolved as well. He wasn't having any more sensation of oral fullness, and repeat examination showed his otoscopy was clear, and there was no further oral fullness, and he was making good recovery. And just lastly, before I finish, I'll just touch very slightly on whether or not there's a relationship between varicella and CVST. Just doing a quick literature search, there are a handful of cases, and essentially it's quite a rare occurrence to develop a CVST after varicella. Now, varicella usually involves it affects primarily young individuals with quite a small or insignificant complication profile compared to those who develop varicella later on in life. So just from a pathogenesis point of view, the working theory at the moment is that potentially the prothrombotic state which varicella can induce due to it having involvement with antiphospholipid antibodies or affecting protein S. It's this prothrombotic state which can potentially give rise to CVST. And then that can go on in a number of mechanisms, be it a vasculopathy path or an immune response, or just direct invasion of the blood vessels. Now, most of the cases that were reported do have favorable outcomes, and I think just a few of them had unfavorable outcomes, and I believe one or two died, but that was due to quite a significant varicella infection initially, which then one of the complications was CVST, but overall they were quite unwell. So in general, the outcomes do tend to be quite favorable. It's just something to keep in the back of our minds, really. And that's everything. Thank you, everyone, for your time.
Thank you so much, Dr. Mohammed.
And we have done a study on this. So I will just present the results and how it goes ahead. So just to begin with, 1 second. Yeah. Just to begin with, a lot of young adults in particular are using the personal listening devices for their recreational purposes. And this kind of noise exposure has been associated with a lot of risk factors if it has been listened at louder volume levels and for extended periods. So there are also reports stating that recreational noise can have similar effects as that of the noise exposure. That is any other kind of noise exposure, for example, the occupational noise exposure. And WHO in 2015 has already stated that PLD usage can be a potential cause for an impairment of hearing. So let's just have a look at the ear. So we know that our ear takes care of the hearing portion and the gravity and acceleration. So cochlea takes the sound and hearing, and gravity and acceleration is taken care of by your semicircular canals and otolithic organs. So the vestibular hair cells, which are present inside the otolithic organs and the semicircular canals, detect the head movements, convert these head movements into electrical potential receptor potentials, and then transmit these as action potentials to the vestibular nerve. So owing to the common genesis that lies between the cochlea and the vestibular system, which is basically with respect to the structural and functional similarities, any kind of exposure or any kind of damage that can be caused to one may likely cause a damage to the other. So considering that and considering the fact that hearing being depleted because of the exposure to the noise, we also kind of think that vestibular system is also at a risk of developing some kind of damage. And the literature has supported this because the sound energy propagates from the auditory system to the vestibular system. And a lot of animal studies and human studies have shown this kind of reason. So there are a lot of tests that are available to test the vestibular system, but there is a lack of knowledge on how the subjective vestibular evaluation or the CVEMP or the OVEMP is going to be affected, or what are going to be the results in personal listening users. Now, why did we use these tests alone? It was because these are cost effective, they are more efficient and easier to carry out, and this can be carried out on any person. So the aim of this particular research was to assess the vestibular functions using subjective tests, CVEMP, OVEMP, that is with varied duration of PLD exposures at more than 60% of the volume in individuals with normal hearing. So to begin with the method, the subject selection went through a process which included inclusion criteria as well as the exclusion criteria. And with that, a total of 136 participants were undertaken within the age range of 18 to 29 years. This is a cross-sectional study, and a consent was obtained from the participants before recruiting them into the study. So the inclusion criteria that was considered was normal hearing, which is less than 15 dB threshold, UCL exceeding 100 dB HL, type A tympanogram with present acoustic reflexes, and exposure to PLDs using Android mobile phones with inserted earphones at volume levels that are greater than 60% of the maximum limit of the personal listening device that they are using. And the exclusion criteria included any individual who were diagnosed with autoimmune diseases or neurological conditions, history of any physical or sports training, and individuals who had or were under the influence of vestibulotoxic drugs or muscle relaxants, and those experiencing any kind of vertigo or balance-related symptoms. So in total, there were 136 participants as mentioned earlier, but each of them were grouped into 4 with 34 participants in each group. So the group A had the participants with the least amount of PLD exposure, and group D had the participants with the highest amount of PLD exposure, that is 3.1 to 4 years. So to begin with the procedure, first the participants underwent a procedure called as microphone in the rear ear measurement, where the dB-SPL levels near the tympanic membrane through the PLDs were measured. Second, the subjective vestibular evaluations were carried out. Third, the C-WEMP was carried out, and fourth, O-WEMP was carried out. So this particular study took care of the subjective as well as objective assessment. So in subjective vestibular assessments, we had Fukuda stepping test, we had Romberg test, and tandem gate test. So in Fukuda stepping test, any deviations that were greater than 45 degrees were considered abnormal. In Romberg test, we looked for a positive Romberg sign, and in tandem gate test, any kind of deviation from the marked line for the test were considered as abnormal. So moving on to the objective test, that is C-WEMP and O-WEMP. This is the protocol that was undertaken before carrying out the study. This is the placement of the electrodes, the analysis time, filter settings, and so forth. So the parameters that were considered were the latency, that is of the P1 and N1 of C-WEMP, latency of N1 and P1 of O-WEMP, peak-to-peak amplitude of C-WEMP, peak-to-peak amplitude of O-WEMP, and amplitude asymmetric ratio. So the result in a discussion, after the statistical analysis, we saw that there was a 100% response rate, which did not correlate with the findings that we observed, which likely says that having a 100% response rate does not necessarily mean that a normal sacculocolic or utriculo-ocular pathway is present. It just says that it is functional pathway. And this probably is the finding because the participants used the personal listening devices in both their ears, and they used it throughout. So further, as I mentioned earlier, the dB-SPL levels were found out from the microphone in the rear ear measurement, which were further converted into dBA value so that we could compare it with the damage risk criteria that are given by OSHA. And we found that all the participants did not cross the damage risk criteria, though Group C saw slightly higher dBA levels that were used through the personal listening devices, but that did not cross the damage risk criteria. And likewise, the participants did not experience any kind of vestibular or balance related symptoms, neither did they show any kind of abnormality in the subjective vestibular tests. So further, the Shapiro-Wilk test was used to see if the data followed the normality. However, the data did not meet the assumptions of normality, and hence the non-parametric tests were required to compare. So the parameters of C-WEMP and O-WEMP were compared for the right ear and the left ear using the Wilcoxon sign rank test, and we did not find that there was any significant difference between the right ear and the left ear, and hence the findings from the right ear and the left ear were combined together for further statistical analysis. So this is the descriptive statistics for C-WEMP. So for across all the 4 groups, the median and the percentiles have been mentioned. Further, this information was recruited for statistical analysis in order to check if there is any significant difference between the groups across the parameters. And we saw that peak-to-peak amplitude of P1 and N1 showed a statistically significant difference. So, which called for further statistical analysis, and hence we carried out post-hoc Dunnett C test, which showed that there is a significantly higher mean difference between Group A and Group C and Group A and Group D. So next we did the statistical analysis of O-WEMP, and this is the descriptive statistics of O-WEMP. Next, we carried out the Kruskal-Wallis test to check the statistically significant difference across the groups and across the parameters. And again, we saw that there is a peak-to-peak amplitude of N1, P1 showed a statistically significant difference. So to find out which groups exactly showed the difference, post-hoc analysis was carried out, that is Dunnett C test was used. And we found that there was a statistically significant mean difference observed between Group A and Group C, Group A and Group D. Likewise, group B and group D. So, and also we found that there was a decreasing CVEMP and OVEMP trend in peak-to-peak amplitudes. That is, which likely says that with increase in the personal listening device exposure, there was a reduction in the peak-to-peak amplitude that was observed in CVEMP as well as in OVEMP. And this is possibly attributed to the stimulation of the macular receptors in the saccule and utricle, which typically lasts for a few hours or days after days of exposure. So any reduction in the peak-to-peak amplitudes across the groups may be linked to the subclinical vestibular damage, same as that of your cochlear damage. And it has already been established, and we also found it in our study, that prolonged exposure to PLDs is often associated with reduced excitability of saccule and utricle. So noise damaging the cells of the cochlea may also impact the saccule and the utricular macula because there lies an intercommunication of the fluid spaces between the two. Likewise, the reduced peak-to-peak amplitude in individuals with NIHL is due to the vestibular damage associated with NIHL, is also stated by a study in 2000. So to conclude, we did not have any participants who reported of vestibular symptoms, and this is probably because there was a bilateral damage and gradual onset of damage, which called for central compensation, and hence as a result there was only subclinical vestibular damage, which is not clinically or overtly presented by the participants of this particular study. So PLDs may not cause a severe damage to the peripheral vestibular system, leading to a diminished VEMP or absence of VEMP, but rather there would be some findings that you would find which indicate that there is presence of subclinical damage that is caused to the vestibular system. So to conclude, I would say that prolonged use of PLDs may adversely affect the saccule and utricular function. Extended PLD exposures may resemble those findings of the cases of occupational noise exposure. One should take a caution, especially the audiologist, when assessing the younger population, because majority of the younger population are exposed to the personal listening devices, may it be for binge watching or maybe for studies or whatever the reason, but they are exposed to personal listening devices. So when they do the assessment, there should be a caution taken in order to not lead to wrong diagnosis. Likewise, negative results in the subjective assessment did not necessarily mean that the person does not have any vestibular functioning. This calls for further objective testing, which is that simple test that you can use is CVEMP and OVEMP. And one should also limit the personal listening device usage for less than 1 hour per day at lower volume levels, which is typically less than 60% of the volume of the personal listening device. So here, when I say personal listening device, it could be one's phone. And these are the references, and thank you.
Thank you so much, Dr. Teja. It was an informative session. If anyone has any queries, they can put it up in the